Hello there, Benjamin Domb from the American Hip Institute. I have the pleasure and privilege of chairing this session on hip arthroplasty here at the Arthroscopy Association of North America annual meeting in Washington, D.C. And this particular talk is going to be on what the sports and general orthopod needs to know, an update on the latest and greatest in hip arthroplasty. My disclosures are listed with the AOS. Hip replacement has been described in the Lancet as the operation of the century, or perhaps the holy grail of orthopedics, one of the best operations invented in the history of medicine. It has led to tremendous difference in quality of life and quality adjusted life years in every study that has ever looked at it. However, hip replacement does have some challenges, particularly for the active or young population. And traditional hip replacements have had challenges including inaccuracy, wear of the components, risk of dislocations, and risk of leg length discrepancies. In addition, it was of questionable suitability for athletes and for young people, particularly because of its limitations in longevity. However, the game has really changed with the advent of a number of technologies and techniques, including the materials, today's materials, the approaches, surgical approaches, and adjuvant technology. So specifically, today's modern materials in most hip replacements done consist of a highly cross-linked polyethylene liner and a ceramic head. So that's the bearing surface. And the acetabular cup and stem are titanium in most of the major hip replacements used today. New approaches, including the direct anterior and the direct superior, are muscle-sparing approaches where we actually go between the muscles and don't cut any muscles at all. And this has minimized muscle trauma, it's minimized recovery, and made possible things like outpatient surgery. Indeed, we're able to do the anterior approach through a bikini incision for cosmetically conscious patients, especially women. And you can see this is a woman here who has had bilateral hip replacements, but you actually cannot see the incisions at all because they're hidden in the bikini line here beneath her garment. Now, adjuvant technologies have changed the game tremendously. Fluoroscopy has been a big one, and fluoroscopy has helped us with understanding the positioning of the components as we're placing them. But X-rays and fluoroscopy are two-dimensional, and traditionally we have judged accuracy of hip replacements with X-rays. Two-dimensional perspective of a 3D object, however, is deceptive, as the good Prince is showing us here. Robotic surgery is next level of adjuvant technology, and we've done a plethora of research at American Hip Institute showing that robotic adjuvant technology has increased our accuracy, it has increased bone preservation, and it has improved outcomes. It has also decreased the risks of leg length discrepancy or dislocations because of the accuracy we can achieve. So delving into those things a little bit further, in this particular study of nearly 2,000 patients, we demonstrated that the robotic-assisted technique achieved by far the most accurate results for cup placement, both with the anterior and posterior approaches. And up to a 94% reduction in outliers has been shown in our research on this topic. It improves bone preservation. By reaming more accurately, we actually preserve more bone, particularly on the pelvic side. And that's relevant because if we preserve bone stock in the index procedure, if a revision is ever needed, there's more bone stock left to work with, which is very important. And finally, it leads to an improved functional outcome. Significantly higher Harris hip and functional and forgotten joint scores were achieved with the robotic technique. And those who underwent robotic arm-assisted total hip arthroplasty in our series were more than twice as likely to feel like they had a normal hip. Most recently, we are now looking at our 10-year outcomes of robotic-assisted total hip arthroplasty, and this is in print currently and will show higher rates of meeting clinically significant thresholds compared to traditional hip replacement, and that those done with robotics are 4 times less likely to have acetabular implant placement outside the safe zone. Now, one might ask about costs, but we've done a cost effectiveness analysis and shown that in over 99% of microsimulations, robotics is more cost effective than non-robotic surgery for both Medicare and private payer insurances. Outpatient hip replacement has been a huge advance. This is something that I began doing in about 2012 in the ambulatory surgery center setting. And it was quite rogue at the time, but since then has been proven to be safe, to lead to high patient satisfaction and potentially lower infection rates. Such that today, I believe more than half of hip replacements in the country, or at least commercial hip replacements, are done in the ASC setting. And robotics and outpatient surgery are perhaps the perfect match because when we are in an outpatient setting, we have less ability to handle problems than perhaps in a hospital setting. So we want to avoid those problems happening in the first place and avoid the need for special implants or special equipment that isn't necessarily on hand. And by using robotics, we eliminate the outliers that may require that kind of special equipment. So what about when someone is too young or too active for a hip arthroplasty? We may be rethinking the limits for total hip arthroplasty because of all of these advances in technique and technology, but we also have resurfacing as an option, particularly for the active male. So in a resurfacing, the femoral bone is preserved. It's reshaped rather than removed. We use a large diameter metal on metal articulation with close to 0% dislocation risk. There has been concern for metal complications because of metal on metal problems in total hip replacements that had metal on metal articulations in the past. But what has been found in resurfacing is those things are only problems with small femoral heads or component malpositioning. So the FDA initially restricted the BHR, the Birmingham Hip Resurfacing, in 2015, but then reapproved it in 2021 for males with femoral heads of at least 48 millimeters and with good bone quality and no sensitivity to metal. So for those people, the FDA, after taking a very close reexamination of hip resurfacing, actually reapproved it because it doesn't have a likelihood of metal complications. And it's applicable in high-level athletes like we've seen in our professional hockey players and tennis players who have undergone resurfacing. We've seen excellent long-term outcomes with Birmingham hip resurfacing. And in our study shown here, we showed that it is likely to feel like a native hip, which is, of course, the ultimate goal. That's the ultimate success, is when an arthroplasty feels so good it feels like a normal hip. And it's even better when we pair it with navigation, as we showed in this study in orthopedics. Here, navigation yielded better clinical and radiographic outcomes. So in summary, today's total hip arthroplasty consists of better materials, muscle-sparing approaches, adjuvant technologies are available which make a good procedure even better, and it can be done in most patients as an outpatient procedure. Robotics can improve our accuracy, our bone preservation, and our functional outcomes, and resurfacing is back and better than ever with navigation. With those things in our armamentarium, we can treat patients like this who have an arthritic hip with an arthroplasty that's appropriate for their level of activity and expect to get them back to a very high functional status. Thank you very much.